couch.
Let me just briefly, being recorded. And will I be able to share my screen?
Let me see.
Be a host.
I can make you a host.
Okay. So this morning, the way it's going to kind of go is just a brief introduction. I'll just jump into that right now. So I know I introduced myself yesterday, and I am an occupational therapist, and I have a maternal wellness business where I go in the home around the island. Well, not all of the islands, parts of the island, mostly the windward side in Honolulu. And I do pelvic health screenings, pelvic floor assessments, treatment. I'm also a doula, a postpartum and birth doula. I've been an OT for 14 years. So I'm bringing a lot of knowledge from all that time in many different settings. And I worked in an integrative setting for a long time and kind of drew all this knowledge I've gained through working with a variety of patients into focusing it more on the mother. So let me just dive in. We're going to go through some slides, and then at the end, I'm going to be more live demonstrating things and have you guys try, if you're able to, kind of participate along with me, going through some simple breathing exercises. I do have a timer going to kind of keep me on track because we are going to go through a lot of things this morning. All right, so let's get some of these slides up. Okay, I think I'm sharing. Okay, and I'm hoping that I am still, can you guys still see me?
Yep, you're good.
Okay, good, because that's important. I still need to demonstrate some things as we go through. Perfect. Yay, so this is what to expect. Postpartum pelvic health. And here we go. This is me. We'll do this on Thursday. This is me doing what I call a morning movement routine. It's a very organic kind of thing where you just are moving in whatever way feels good. So here's my intro. You can find me at windwardmaternalwellness.com. I'm on social media. And I also have a beautiful Facebook group platform as well, where there's myself on there, but there's other women's health professionals speaking and talking and sharing. Okay, so these slides are not all the detail. It's really like the key points from the course online. So when you have a chance, it's in section 3 and 4, I think. Okay, Kirsten's nodding. Section 3 and 4 of the online course. So I don't want you to feel like today is like everything you need to know, because a lot of the detail is actually held within the course. And this hour is intended for me to really highlight some key points and mention some things that are, or talk about some things that are really kind of complex. And I think if you hear it multiple times in multiple ways, you're more likely to soak it in. So if at any time, I think Kirsten can kind of monitor, well, you can't really see the chat right now, but when we get out of it, if you have questions, type them in the chat. And hopefully we'll have some time this morning even to answer some of those. Okay, so let's start off and make sure everyone kind of understands, what is your pelvic floor? It's become something we're hearing a lot more about in just day-to-day conversations. I think women giving birth, even just 10 years ago, pelvic floor wasn't really in the language then, but it's becoming much more so, and women are interested and want to learn and want to know. But what the heck is it? So before I go into, these are what it does: the elimination, intimacy, organ protection. But I have my handy dandy pelvic model. So I always like to demonstrate kind of where it is. So this is your pelvis. This is the front of your pelvis, your pubic bone. In the front, these 2 points are your sit bones, your ischial tuberosity, and in the back is your sacrum. So your pelvic floor are the muscles. Your pelvic floor is nothing, it doesn't have nothing to do. Of course, everything's connected. But your pelvic floor is not the bones, it's actually these muscles, which is this sculpture is showing. And what's so neat about these muscles is they're a different type of diaphragm, and we'll talk like to our breathing diaphragm. And they kind of mirror our breathing diaphragm. So if you look inside the pelvis, it actually looks like a bowl, and it is a bowl. It's our pelvic bowl, or our, and it supports so much, and it's intricately woven. I have to put that down to do some of my other. So it's like a weaving together of 14 different muscles. There's of course ligaments and fascia, soft tissue. But when we talk about the pelvic floor, we're not talking about the stuff that I took out, the organs, the bladder, the uterus, the vagina, and the rectum. These are the organs that are, here we go, that's how it goes, in that space. That's not your pelvic floor. Those things are there, and they are supported by your pelvic floor. So the pelvic floor muscles, their role is for elimination, meaning the holding in and releasing of urine, stool, and babies when desired. Although the baby thing is a little more automatic. Our body actually does that more for us than consciously. But the urine and stool, we very much should be able to consciously hold in and consciously. Stool is kind of the middle ground there. Anyone who's actually had a baby knows stool, like it can be kind of similar, but it's being able to hold and release when you want, where you want, and your body is supposed to do that for you without concern. So intimacy, this is one that often gets glanced over just in our culture. This is something that people do not like to talk about openly. But a properly functioning pelvic floor means you're able to engage in pain-free sexual activity and attain orgasm. Organ protection, the ability to protect and provide buoyancy for pelvic organs. So this one sometimes can be, so if you think of this woven mesh, think of like a trampoline, right? It goes up and down and it gives, but it never breaks. That's what we want more with the pelvic floor than a floor, like your wooden floor. Well, if you jump up and down on that, and that's tissue, there's nerves there. It's gonna hurt. It's rigid. Our body needs that flowing nature. So a common thing in women with or without children is an overly tight pelvic floor. And that would be a rigid, like hard, this is an extreme example, but it's going to be painful because there's no movement or give through your day. And it can be quite common and often overlooked for years and years. And then it holds, so the internal, external anatomy, like the genitalia and the internal musculature, it's just what holds everything together. If we think everything above our pelvic floor, our spine, all our organs, all the way up to your brain, which weighs, 10 pounds or something, all of that is being supported as you go through your day by your pelvic floor. So it's a very essential structure, and it's very intricate structure. So I'm going to keep going. All right, so this is something that I don't mention anywhere, and I want to make really clear about pelvic floor dysfunction. C-section versus vaginal delivery. So a lot of women may think, oh, well, if I have a C-section, like there shouldn't be anything going on with my pelvic floor. And that really is not true. It is less, you're at less risk for certain things, but you don't get a clean slate. Many women who've had C-section will and do have pelvic floor dysfunction, and often they don't seek out treatment as quickly or at all because of this belief of, well, a baby didn't come out vaginally, it couldn't be that. So both ways of delivery can result in pelvic floor dysfunction, but both ways of delivery do not mean that you will have pelvic floor dysfunction. In fact, when I screen women, and the current statistics on pelvic floor screening, which we'll go into a little bit later, is that only about 25% of women will have anything that needs to be treated. So, there's I'm talking about a lot of kind of scary things today, but going back to limiting belief is knowledge is power. If you know, you can better take action if something comes up. If you don't know, you don't know. So my hope is that you come away through the course and today just feeling like you know more about how to identify in yourself, or maybe even sister or friends, if something's going on that they need to get checked out. So C-section considerations, of course, there's the scarring, and yes, it's on your abdomen, but it's very close. So here's my uterus. It's obviously not this small when you give birth. And your bladder is like right under here. So if you're laying down, and they do the incision very low on the uterus, so your uterus is huge when you're a baby in there, but very low. And if you think about it, we go through actually the 7 layers of tissue, and the bladder is sitting right near there. And when the scarring occurs, the healing occurs, if that can make restrictions of tissue that put pressure on the uterus, on the bladder. So scar management with C-section is very important and often overlooked. Prolapse, we'll get into that more. Constipation, urinary incontinence are all possibilities post C-section. And with vaginal delivery, the other big difference is, of course, there's risk of tearing, or episiotomy, which really isn't done in Hawaii anymore. But tearing and urinary incontinence, pelvic pain is more common with a vaginal delivery than a C-section, because of all that. There's so much more pressure and things get shoved around a lot more. And then, of course, prolapse. Let's keep moving along. So who needs pelvic floor therapy? So this is my viewpoint on this. I really believe that anyone who has carried a baby within their body for any length of time should have a screening. And a screening, I'll go into more detail later what it entails, but my screenings are a half-hour appointment in your home, and it's doing a quick version of my assessment. Now, if you were in France or most of the European countries, you would be referred for an assessment automatically at about 6 weeks postpartum. Similar to how we do the 6-week appointment here, but they say, okay, 6-week appointment with your doctor or medical provider. And then here, also go see the pelvic floor therapist to get checked out for the muscles, because doctors are not, especially OBGYNs, midwives, they are not specialists in muscles and muscular function and dysfunction. Therapists are. So we just overlook that in this country completely. And so I really recommend screenings, which can be hard to find. Not many providers offer them. They don't require a medical referral, but that is something that's I prefer. I think it's a good practice. So assessment is different in that it's much more in depth. It's an hour and a half session. We're having much more conversation. I'm trying to learn a lot more about what's going on, because usually it's because we already suspect that there's something going on. There's been a referral from a doctor, and we want to dive into trying to peel back those layers of what is happening. So it's much more in depth. I need a sip of my tea. And then treatment, of course, only proceeds if something is actually going on that needs treatment. Okay, the following are signs and symptoms there's a few typos here, excuse me. Signs and symptoms that you should be aware of and seek out pelvic floor therapy for. So leaking of urine beyond 4 weeks postpartum. Okay, I want to stop here for a moment, because there is no guideline. You ask one pelvic floor therapist, they're going to say they need to see a pelvic floor therapist if they have leaking from day 1, or Others might say, oh no, like it's no big deal. Like your doctor might be like, oh, it's so common. Or your mom would be probably like, oh, that's what happens when you have a baby. So I kind of settle on this 1 month time frame because, well, for one, I've had my own pelvic floor dysfunction and it's mostly been around leaking of urine. And I believe, especially with the vaginal deliveries, that your bladder just gets smushed and crammed out of the way to give birth, and it gets mad, and it's not going to cooperate right away. And that is normal. What you look for in that first month is that you're starting to feel like you have more control and more ability to hold and more ability to release when you want to. And if it's progressively getting better and is better by a month, you're good. It was just the pressure and the tension, and I don't like to use the word trauma, but like there's a lot going on down there when you give birth. So give yourself some grace, give yourself some time. If you're leaking in the hospital or when you first get home, don't freak out. Your body just birthed a baby. Give it some time. So I that's where I say 4 weeks. But in that 4 weeks, I give you some suggestions on what you can be doing to kind of help your body start working better again. Leaking of stool, really at any time. There's some considerations here, of course, if you've had a very big tear, like a stage 3 or stage 4 perineal tear, that often is a symptom that goes along with that. And a similar progression would be, okay, is it getting progressively better or is it not improving? But if you haven't had a tear like that, leaking of stool is, of course, a reason at any time to seek out pelvic floor therapy. Pelvic pain. So pelvic pain is so, like, a lot of you, when I say pelvic pain, might be thinking like pain in my pelvis. Not, yes, that's included, but it's more about the pelvic pain, like in your vaginal area, in your vulva, in your anus, in your perineum, and inside in your vagina. That is not normal. Of course, immediately after giving birth, you're going to have pain there, and that's normal. So again, by the 6-week checkup, there really should not be too much pain. And if there is still a concerning level, a lot of doctors, I think, kind of just say, oh, it'll get better. And I challenge that, well, it will get better in many cases, but it could get better a lot quicker with probably just a little bit of pelvic floor therapy. Inability to Kegel or confusion around Kegeling or feeling like it hurts when I Kegel, or I feel like I only can do it in the back near my anus, but I can't do it in the front. That's a good reason. A lot of women can kind of lose that mind-body connection of like understanding where things are and what things are doing after pregnancy. And it's a coordination, strength / proprioception. So proprioception is knowing where we are in space. So it's often a combination of those things that once we pelvic floor therapists are like cue you into, okay, this is what it should be doing, and you kind of can rearrange and remap that coordination. Feeling of pressure, heaviness, falling sensation in the pelvic floor. These are signs, but not necessarily symptoms of pelvic organ prolapse. So if you have those, that didn't say that good. If you have those symptoms, it doesn't mean you have prolapse. It means we should screen you for prolapse. And I don't know many doctors who do that automatically. I do it in my pelvic floor screening. So in that 30-minute visit, I'm screening for prolapse. And we'll get into that more. Inability to return to intimacy by 6 to 12 weeks due to pain. Now, I have a whole section in the course, Return to Intimacy. But I do think that often a barrier to this, there's many emotional reasons. It's a very emotional thing as well as a physical thing. And on the physical side, I'm saying 6 to 12 weeks due to pain. Now, there may be more emotional reasons that you're not returning to intimacy in that time frame. And that can link to the physical, and a pelvic floor therapist can be helpful, but sometimes you need someone with like a psychologist or counselor or sex therapist to assist with that. All right, so here are the takeaways. So in the course, I go through common conditions in postpartum related to the pelvic floor. And right now I'm just going through the takeaways of that. So constipation. Constipation. It's so common postpartum, but it really needs to be able to be resolved very quickly. I'm saying 1 week postpartum, or it becomes a concern. And the reason I say this is because repeated or chronic constipation causes added pressure to your pelvic floor, and over time can contribute to pelvic floor problems. So both myself and Kirsten in the course go into a lot of ideas and ways to manage constipation. So if you're feeling, I think it's great if you're pregnant and you read up on what to do about constipation. So from day one, you can start doing those things. Now, if you find yourself in that pattern of chronic and repeated constipation, diving into those recommendations. But if those things are not working, sometimes even working with a combination of a doctor and a pelvic floor therapist can be helpful. I'm going to tout for occupational therapy because we're really good at looking in at rhythms and routines in your life and how they link to your body function. And my role a lot with constipation is not so much the constipation, but how you're going through your day and your activities and your stress and your nutrition and how that's contributing back to the constipation. So let's keep going. So this one is urinary incontinence in postpartum can and does occur quite often. However, it's never normal. So in that 4 weeks, that 1 month time frame that I'm saying, give yourself some leeway. Things that you can do is keep a bladder diary. Now, it's not that you're keeping a bladder diary for that entire month. It is 3 days, okay? And I wouldn't do it right away like this. I would never recommend a mom 1 or 2 weeks postpartum, within 1 or 2 weeks postpartum, to keep a bladder diary if you're leaking, because I've had a lot of clients, it's more birth doula clients, call me and be like, oh my God, I'm leaking. And I'm like, it's okay. You just had a 50-hour labor like a week ago. Your body's still just trying to figure out what the heck happened and your bladder's pissed off. So just keep wearing the pads and monitor. And then come 2 weeks out when your body should be settling down and kind of, that initial swelling is all gone and things like that. That's when it might be helpful to keep a bladder diary and see what are the purpose of that. And the bladder diary is in the course, it's in your workbook, is to identify patterns. Most moms, I think, once they do it, can kind of see like, oh, I see some patterns. Sometimes it takes some keener eyes from someone who does this all the time. And I also recommend to consult with a pelvic floor therapist early. You can absolutely work on urinary incontinence within that 6-week time frame. You don't need clearance from a doctor to work on urinary incontinence, because I'm not doing anything internal when I treat urinary incontinence postpartum within that 6 weeks or even 8 weeks. It's only external and kind of external things. Okay, let's keep going. Trying to keep myself moving along. All right, perineal tears. So there's good and bad news here. The bad news, of course, is that it's really not preventable. There's things you can do and there's many, this is a very short list. So, I mean, you can search the internet for like 101 ways to not get a perineal tear. But at the end of the day, there's a lot of non-modifiable factors, things that you cannot change, including your genetics. that tie into your risk of getting a perineal tear. The good news of that, it being not preventable, is that actually a little bit more than 95%, the stats are all over the place, but generally I think most would agree that over 95% will be a stage 1 or 2, and those usually require no further intervention. So your chances of having one of these big tears is really low. And if you're doing some things to reduce your risk, it's probably even lower. So pelvic floor massage. I'm sure some of you have heard of perineal massage. And perineal massage is often suggested. And so this is the anus. Don't do it on your anus, wrong place. Vagina. And your perineum is that space between. So perineal massage is when you're taking like olive oil or some sort of lubricant and you're just kind of stretching this bottom. They call it the vaginal fourchette. And you're just and I'm like pushing. So you would be massaging like that. Okay, great. Fine and dandy if you have a baby in the next hour. But what happens when we put like lotion on our skin here? And like 4 hours later, is our skin nice and pliable and lotioned up still? No, all the effect has gone away. So what I recommend instead, the combination means demonstrating. So think of the pelvic floor muscles. The muscles during birth have to let go and let the baby out. Your muscles are tight and you have tension. They're like this. And the baby's coming out. They don't want to let go. And what happens? And it's a little traumatic sounding. That's what a perineal tear is, when that skin and musculature, it's often linked, this is my theory, linked with tight pelvic floor. And it just gives way, like the muscles aren't letting go. So more and more nurses are learning like just pelvic floor muscle release, and oftentimes midwives know. It's often back near the anus. These are your big, the strongest pelvic floor muscles, and just going in and finding trigger points externally to release them. And some nurses are now even being trained to go internally in the vagina during labor and releasing muscles. Okay, so this is not a technique that, the hard part of it, it's not a technique that you can pinpoint exactly where you need it if you're not trained. But what I instruct is, so the easiest way. So imagine, so this is a woman laying on her side. Her head is coming up this way. Her butt is in your face, okay? So her big butt is coming here. This is her anus, and her butt is coming this way. Or it could be a small butt. And you're going in at your crack, okay? And you're pressing on the muscles right near your anus. This is the common ones that are tight and don't want to let go because of varying reasons I won't go into now. And you're just kind of grabbing, if you can see my hand, like around, so your anus is here, and you're grabbing, and you're just kind of like pressing on these walls, deep in. So it's not your glute's like all that fleshiness. It's deeper and kind of on the side walls. You can also just poke around externally and find any points. Ooh, that hurts. That feels tender. It's probably a muscle trigger point. Press on it for 90 seconds and it might let go. And if you're completely lost or you have lots of pelvic pain or tightness, seek out a pelvic floor therapist. They can easily show you how to do some releasing or do it for you. And hydration, I'm going to go through this quick, but hydrated tissue. So hydration not topically, but more internally, meaning through electrolyte water, milk, juice, not caffeine-free tea, anything is going to make your tissues more elastic. So when women are leading up to 37 weeks plus, I say just make sure you're hydrated every single day. And just water is not actually the most hydrating. Certainly electrolyte water is much better, but so is milk, if you're someone who drinks milk, is very hydrating, and juices are very hydrating as well. Okay. Pelvic organ prolapse. So this is a shift in tension on a pelvic organ causing a shift in sensation. So I'm going to skip to this is my vagina falling out of me one, because that, I think, if you know what prolapse is, it's often what people are thinking, and it's almost never what is actually happening. It is sometimes what is happening, and it is a type of prolapse after hysterectomy, but it's very uncommon if you've not had a hysterectomy, which most early postpartum women have not. So the short answer is no. It's just the sensation making it feel like that. So what it is, the most common one is actually a bladder prolapse. So your bladder, this is the front of your body, and this is your butt. A bladder prolapse is just when the bladder just kind of shifts. Now these are hard. It's much, you might see this demonstrated with balloons or soccer things. And the bladder is just kind of maybe like tilted a little, and it's pushing on the vagina. It makes it feel like pressure and heavy. It can give you back pain. It's another symptom. So, but it's nothing falling out of you. So I think getting that fear of like, oh my God, like my organs are coming out is really important. It's quite common. But it's not as widely talked about as things like hemorrhoids and urinary incontinence and perineal tears. I think those topics are much more often talked about. But it occurs in about 50% of women, not just childbearing women. So it's not uncommon in college athletes. They often are asymptomatic and have no idea. And there's a lot of debate on what you do with that asymptomatic. I won't go into what I think that's irrelevant. Let's keep going. So will Kegels make it better? Not usually. You usually need a more nuanced approach led by a pelvic floor therapist. It's not really a lack of strength that is causing this to happen. It's like I said in that top line, it is a shift in tension that's causing a shift in what sensation you're receiving in your brain. So what does help? A personalized combination of manual muscle work, meaning oftentimes there can just be uneven tensions in your pelvic floor, and a therapist with like a really keenly trained hand can find, okay, this side of your vaginal wall feels much tighter and this side feels much looser. Let's even that out through manual work. Postural training is so important and sometimes overlooked in pelvic floor therapy. How you're positioning your body through the day impacts prolapse. Improving abdominal pressure, we're going to go into that a little bit shortly, and some strengthening. All right. So what to expect when going to see a pelvic floor therapist? I go over this really briefly in the course, so I wanted to dive into a little more detail because I think sometimes a barrier to seeking pelvic floor therapy is because women are like, oh my God, what are they going to do to me? Like, what do I have to go through? And it's really, I think knowing what to expect is helpful. So this is what I do. Not every pelvic floor therapist is going to operate in the same way. So I just do a pretty detailed intake phone call where I'm just this is usually our first conversation, just trying to learn what's going on with you, how it's impacting your life, and what prompted you to call, and what are you hoping is the result of you seeking help. A pelvic health questionnaire. So a questionnaire, sometimes I'll ask clients to fill out a bladder diary depending on their symptoms, and a health history form filled out and returned before we meet, because I review those in great depth to kind of know what is going on and be prepared with deeper questions for that in-person visit. This is a really important aspect, because if we spend the time in that assessment and going through all this, it's just a waste. So I want to go in ready, kind of knowing what what is going on and what I might be looking for. And then it's always best practice to have a referral from a doctor. So I do request that. So during our initial assessment, we definitely have, so this is not a screening, this is like the hour-and-a-half assessment, conversation about your primary concerns, goals, as well as your daily roles, routines, habits, activities. I'm looking at posture, breathing patterns, abdominal integrity. You'll learn why this is important once we're done with these slides. External pelvic floor assessment. This is with your clothes off for the most part, but I'm just looking at like trying to see, do you have any of those external trigger points? How are your muscles in the area? Look for I look at your glutes, the muscles that bring your legs together, your adductors, and just varying areas. I'm looking at your skin and the health of your tissues and all of that. If you had a tear, I'm kind of assessing like how is that looking. Internal pelvic floor assessment. So this is the part where women are like, what are they doing? So you're not in stirrups. There's never a speculum in sight. I don't even own one. I am assessing your musculature. So if this is your vaginal opening, it's never more than one finger. And I'm going in and just feeling, what are the walls of your muscles feeling like? Are they tight? Are they tense? Are they tender? Do you get pain? And I go in as far as my third knuckle. It's kind of interesting. There's 3 layers of pelvic floor muscles, and the first layer is approximately to my first knuckle, the second layer to my second knuckle, and the third layer to my third knuckle, which is kind of neat if you're an anatomy nerd like me. So single finger insertion into vaginal canal to assess for muscle strength, coordination, endurance, and pain. So I'm also asking you to Kegel as my finger is inside to see just how does it feel? Is it just strong on one side, or is it strong on all sides? Is it lifting or is it not lifting? Is it not even present? Can you only feel a little twitch? A lot of information can be gained from that internal assessment. However, it is not necessary if the patient is not comfortable. In fact, I would never do it unless I get very explicit and almost enthusiastic consent to do so. Because a lot can be gathered through these other things that can help you. In fact, a lot of clients can even improve through breath work is all they need. I hope you understand that more by the time we're done this morning. So this postpartum pelvic screening, this is that quick one. Again, it's pretty similar before we meet and during. I'm just going through screening. So screening is like a much quicker look. A posture, diastasis, visual external pelvic floor, internal Kegel test, and not spending as much time feeling all the areas. There's a lot of places I could spend time on. I'm just having a quicker Kegel test. And I'm always screening for prolapse. This is really important to me because I feel many providers do not do it. And many women don't know that they're having symptoms of prolapse. So they don't report it to their doctor. And unless they report it to their doctor's not going to screen. So I just automatically do it. All right. So pelvic health and the pressure system. I'm going to pull up this slide. This isn't going to stay up, but this is what we're going to go into now. So it's step 3, lesson 4 in the online course, posture, alignment, and breath. But right now it's so critical to pelvic health, and it's one of the things that you can take away and positively impact your pelvic health today. And so I'm going to demonstrate how we breathe and how it can positively, or not how we breathe, but like ways of breathing, and how it can negatively or positively impact your pelvic floor. I'm going to jump to the third one. I'm going to demonstrate what a paradoxical breathing pattern is and how you can change it. And then we'll talk a little bit more about how simply focusing on improved breathing patterns can improve your pelvic floor symptoms and strength and coordination and awareness. And then as time permits, we have about 20 minutes left. I'll dive into some exercises, relaxation. All right, let me get out of here. get lost getting out of here. Okay, there we go. I'm back. Okay, why? Let's see. Let me like refocus. Okay, I'm gonna take off my headphones. Okay, I have to move around. Can you all hear me okay? Okay, good. All right, so how we breathe and how it can negatively or positively affect our pelvic floor. So I'm going to be moving around, so bear with me with all these camera changes, just so you can kind of see what I'm demonstrating. So we breathe, it's our diaphragm, right? And our diaphragm is this dome-shaped muscle right here. And feel free to stand up and kind of move around with me and feel this on yourself. I think that's a really good way to practice and just going along with me through these, what I'm telling you, and just trying to feel it on yourself is so important. So bring your hands around your ribs, and I want you to all take a deep breath in and a deep breath out, and just observe what you feel. Not trying to make anything change. You do want to be taking a nice deep breath in. It makes it easier to feel what you're feeling. Okay. So now what you should be feeling is that there's a lot of movement in your ribs, and that there's movement in all angles. So as I breathe in, because I practice this a lot, you should notice my hands really go whoop. So I'll show you. See that movement to the side? Now you want to watch out that it's not, you're not doing your shoulders. You want to feel with your hands that your ribs are going broad and down. Okay, now with the breath, I change this direction. We're watching the front. I'm going to get closer so you can see my hand better. So I'm going to breathe in. You see that little like lift out? So our ribs should be moving forward as well. And now I'll turn back. Look, watch my thumbs as I breathe in. You kind of do like this motion, right? So it's showing some back movement. When I'm assessing for someone's breath, I'm looking that they're showing this 360-degree diaphragmatic movement. That means that their diaphragm is working well. It's fully expanding and contracting. A lot of times after pregnancy, we're not doing that. And a lot of people who are not, like men often are not doing this. So it's not necessarily a pregnancy issue, it's a human issue. But women postpartum can have rib things going on. And so it's really great to look at that breath and help that mom get that breath back to normal. Why does this relate to your pelvic floor? Okay, let me tilt this down. You're not going to see my face, but that's not the important part. Oh my God, stay. Okay, so when you're breathing in, I inhale. When I inhale, my diaphragm dips down. When I exhale, it domes up. It pushes up to get that air out. So inhale, down. Exhale, it lifts. Now I'm going to show you what your pelvic floor is doing. Inhale, exhale. Inhale, exhale. It's doing the same thing, right? It's mirroring. They're both going down, they're both going up. If you remember one thing from today, remember that when you exhale, your pelvic floor lifts, and this is when you should kegel. We'll nail that into you now. So as I breathe, I don't like you not seeing my face, it feels weird. As you breathe in, I want to clarify, because your pelvic floor is not the same as your breathing diaphragm. It's a group of muscles. Your breathing diaphragm is one muscle. But with the inhale, your pelvic floor softens. So if you were sitting down, you may have felt, and I'll have you do this in a moment, a softening of the pelvic floor. And when you exhale, you should feel kind of a little light lifting. It depends on how in tune you are with your pelvic floor. And to help you get more in tune, I will often have my clients link, okay, as you inhale, I want you to try to reverse Kegel, which is pushing out, down. And then I want you to Kegel with your exhale and lift up. So I sit down. So I want you to all kind of go through this with me. So take a big inhale and kind of make sure you're up good on your sit bones. If you're slouching on your sacrum, you're not going to feel anything. I have a guided relaxation in the course that takes you through this as well. And I speak about it in at least one video in the course. Okay, so as you inhale, I want you to feel a softening, a spreading of your pelvic floor. And as you exhale, I want you to feel that slight lift. I do not want you to do a Kegel. Inhale, softening. Exhale, lifting. Inhale, softening. Exhale, lifting. Now add a Kegel. So inhale, push out, like you're pushing you're bulging out. Exhale, lift into a Kegel. Inhale, relax that Kegel and push it out. Inhale, exhale, exhale, lift into a Kegel. One more round. Inhale, softening, bulging, pushing out. Exhale, lifting into a Kegel. Okay, so you may initially, when I didn't have you do a Kegel, you may have been like, what the heck? I feel nothing. You're crazy. And no, I'm not crazy. I will say that with time and practice, you will start to observe this. And when you do start to observe this, you have already impacted your pelvic health because you're understanding how it links to your body and your just movement and breath. Okay. Now, if you're having trouble, and it's always good to do, I take that back. It's not always good to do Kegels. Some women, Kegels can cause more issues. Kegels is I have a whole section of Kegels in the course. Kegels are a very complicated topic as a pelvic floor therapist, but it's okay for this purpose if you're trying to find that link, to do a Kegel. If you're having pain with it, talk to a pelvic floor therapist or your doctor. Okay, so exhaling is that lift Kegel. Inhaling is kind of relaxing and making sure I always do this action like pushing out and down and spreading, like that opening of the flower, okay? And the flower is coming down. All right, so why does this matter? How can it positive or negative impact? Let me do that quick demo. So if you are inhaling and you're Kegeling or lifting, and then you're exhaling and you're dropping, well, your hands are opposite now, right? So when you're here, pressure, pressure, pressure. When you're here, kind of this weird void that you're never supposed to have. Pressure, void, pressure, void. It is a version of that paradoxical breathing pattern. And over time, that added pressure can cause pain in the pelvic floor. It can contribute to urinary incontinence. It can contribute to chronic constipation. It can contribute to everything we just talked about. Prolapse, for sure. Prolapse is very much a pressure tension issue. So the best thing you can do is knowing, okay, when I Kegel, I lift my pelvic floor. When I exhale, I lift my pelvic floor with a Kegel. And when I inhale, I relax it down. And I have to completely let go and relax. So feel a big difference between the inhale and the exhale. I hope that makes sense of how that can be negative. The positive is because if you're using your body the way it was meant to be used, everything works better. So to that paradoxical breathing pattern and how to change it. So a paradoxical breathing pattern is basically this, and it can be quite common postpartum as moms like trying to suck it in. So I exhale and I inhale. And I exhale. I'm always like doing this wrong. I have trouble flipping it. Hold on, let me think about this. So exhale. I'm sucking it in on the inhale. Sorry, I always reverse that. When I inhale, I go, right? And I exhale and I go. So you're walking around inhaling, trying to suck it in. That's the paradoxical breathing pattern. Sorry, my first demo, I always get that flipped. So we don't want to be inhaling and holding in our pelvic, our stomach. It adds so much pressure. And it's similar, but not exactly the same as a Valsalva maneuver, which some of you, if you've done weightlifting and stuff, may know, like they want you to hold that tension to have more power. Valsalva maneuver can be done safely with your pelvic floor, but should never be attempted early postpartum. And this paradoxical pattern, this sucking it in with your inhale, it just doesn't make sense. Why are we trying to push our stomach in as our lungs are dropping down? You're just jamming everything together when really when we inhale, we want to soften. And when we exhale and your lungs and your diaphragm are moving out, that's when we want to engage the muscles and lift up and in. Okay, so let's have you try feeling how your core muscles, so one of your key core muscles is called your transverse abdominis. And it's the muscle that goes, I'm going to lower this again. But it really goes kind of between your hip bones. So the sticky outy bones in the front. We have this kind of corset muscle. It's very big. It comes up and around too. But the key part to cue in your mind is between your hip bones. So as you inhale, I want you to soften your core. And as you exhale, let me back up. As you exhale, I want you to try to pull your hip bones. They will never move, but this is how you get the muscle to activate together. So inhale, soften. Exhale, pull your hip bones together. And you should feel a banding tension between your hip bones. Inhale, soften. Exhale, pull your hip bones together. Inhale, soften. Exhale, pull your hip bones together. Okay. So you should feel, and you can give me a thumbs up or a yay in the chat or whatever, that banding between your hip bones. This is one of the most important initial exercises a new mom can do. You can do this the day you give birth. Is just exhaling and being like, can I feel something happening between my hip bones? It feels like tension. To activate that transverse abdominis. Awesome. Some of you are like, yay, I felt it. So you can do this also throughout pregnancy very safely. This is just a muscle awareness exercise. You're never going to get sore doing this exercise, but you're going to keep that mind-body link through pregnancy, and then helps prepare your transverse abdominis, which is really a key deep core muscle, to be strong for movement and exercise and lifting and doing all the baby things. So I'm pausing for a second to think if I'm missing something I wanted to say. Yes, so your transverse abdominis during pregnancy gets totally just not destroyed, but disconnected. In many moms, especially if you're not actively kind of aware of this muscle and aware that you can continue contracting it. And it can be as simple as that exercise of like, I'm sitting at my desk and I'm trying to bring my hip bones together with my exhale. And then I'm letting it relax. And then, and you feel that like just corseting in of your muscles. And then with with all of these, so that 360 breath where we're trying to breathe in all angles, it's great to do it in sitting or standing like we did. And the same with the TA, we call it TA, transverse abdominis exercise, sitting or standing. But even better is, and this is what I'll often take clients through who are having off breathing patterns or just feel disconnected with their breathing postpartum, is doing it in all different positions. So we'll do it on all fours. We'll do it side lying. We'll do it laying down. We'll do it standing up. We'll do it then, the highest level is as you do something. So as you squat, or as you pick up baby, or as you carry a car seat. So making it into that functional, helping it carry over into your functional day-to-day activities. And that takes time and awareness. You have to be really able to do it in every position. So front, back, left, right, the main ones are sitting, standing, all fours, and laying, and side lying is always good because you can kind of focus on one side better. But then you also, so imagine the rib, the 360 breath side lying, which I demonstrate in the course, definitely in the course. You're going to get that feedback from the floor on your bottom bottom ribs, and you're going to feel that nice lift on your top ribs. Okay. So I think we have about 3 minutes, so I'm going to stop there, but I'm more than happy to take a question or two, or we can say aloha and we'll see you back here tomorrow. I don't know if Kirsten wants to chime in with anything.
Yeah, if anybody has any questions, feel free to jump in. Tomorrow's going to be a packed day. Today was so great. Thank you so much, Hillary. I learned so much, and I'm sure all of you did as well. Like she said, in the course, in her sections, she goes in depth. There's videos of her in there. And it's really the deep dive version of what she did today. And what she did today was already so much. So it's really rich with information about your pelvic floor. And then tomorrow we're going to be talking about postpartum nutrition and mental health. We very much believe that everything's holistic here. And I just really feel that those two things are very connected. And then tomorrow we also have our coffee hour that's going to be happening at 2 p.m. Hawaii time. I think that's, what is that? 7 p.m. Central time. Ooh, that was my dog. So if you want to jump on that'll be really fun. It's going to be open forum, just chatting and talking about different things about postpartum or questions you have. It'll be a really fun time of community. But if there's no questions, we'll see everybody back here tomorrow morning, bright and early if you're in Hawaii at 7 a.m. Thank you guys so much.
Thank you.
Bye.